It's hard to believe it was just a month ago that much of the world was still wondering if the coronavirus could be stopped in its tracks. That's a month ago or so. I mean, who wanted to imagine the realities of a pandemic? Since then, driven by necessity and will, there's been this convergence of mission in every time zone and hemisphere to reduce the spread of the coronavirus and to get out in front of it medically, operationally, and scientifically. This is as complex as it gets, societally speaking, and wouldn't be possible without healthcare workers and professionals, an informed public, community mobilization, public health levers, and the sharing of information across geographic boundaries like never before. Real-time learning systems springing up to continuously improve the response, especially treatment, are among the results. So that's our focus. This is the third in IHI's series of free virtual learning hours devoted to COVID-19. And the we for our series includes two regulars who are at my virtual side, IHI President Emeritus and Senior Fellow Don Berwick, and IHI President and CEO Derek Feely. We have additional guests today. Pedro Delgado is the head of Europe and Latin America regions for IHI. And then we have this amazing team from London and surrounds. James Mountford is the Chief of Quality and Learning, NHS Nightingale in London, and Director of Quality for Royal Free London. Joining James are members of the leadership team for NHS Nightingale, and they include Mike Roberts, Dominic Alwood, and Richard Balmer. So hello to the panelists, hello to everyone joining us. You're going to hear from our panel for about the first half of the show, and then we'll turn to your questions and comments. Be sure to chat to all participants so everyone can see what you're sharing and dialogue with you if they so choose. So I always like to begin with Derek. Derek, IHI has a lot of global partners and colleagues, and you crisscross many regions of the world, forging, nurturing these connections between healthcare professionals and leaders, because there are similar problems and methods that can help healthcare systems in many different countries. Improvement has been the thread, and my question to you is it still the thread in this pandemic? Thanks, Derek.
So, Madge, I think the short answer is yes. We believe it is. And just to try and provide some rationale for that, as this slide shows from Johns Hopkins, this is a truly global pandemic. And the US might have the most cases by far, but if you just look at the number at the bottom, towards the bottom left of that screen, that number 184, that's the number of countries and regions that are affected by the coronavirus outbreak. And global problems demand global solutions. And our ability to tackle problems of this kind of magnitude and complexity will depend to a large extent on our ability to innovate and create new knowledge. But I would argue even more important will be our ability to share that knowledge across systems, not just with our neighbours, but across the globe. And those opportunities to share knowledge and learning are enhanced, as you see in this next slide, by the fact that in many countries, the trajectory of the virus is similar. And therefore, we can, along that trajectory, identify some learning opportunities, some ways to more deeply understand what are the corrective actions that we can take, and how can we surface those and share them in as close to real time as we possibly can. And as we said when we kicked off this series, Madge, that's where improvement science comes in. That's why we want to hear today from our colleagues in the UK who have, I think, some really novel and interesting approaches to share with us. Also, I think where IHI comes in, that we have a duty to be the home for this global learning community. And we're asking everyone on these calls, and indeed on everything else that IHI is doing just now, to look through an improvement lens at the coronavirus challenge, to act on the system and share what you're learning from those system level changes, to pay attention to the psychology of change, and to share what you're learning along the way. And I'm sure we'll hear some of that from our friends and colleagues from London today. You know, Madge, IHI has long talked about all teach, all learn, all teach, all learn. And if ever there was a time for that, it's now. And so that's what we're going to try and do in the next hour. Thanks, Madge.
Okay, thank you so much, Derek. Don Berwick, over to you. You, like Derek, are keeping a keen eye on what's happening in different regions and different countries. And I guess my question for you also to kind of set the context, what looks different? Derek spoke to some similarities, but what looks different from region to region? And how easy is it right now for health systems to benefit from this global expertise, given all that's pressing right in front of them?
Thanks, Madge. And may I also thank our colleagues from London. It's a delight to have you with us, and I know how busy you are. I think the opportunity for learning is bigger than I've ever seen before. IHI has had global brains since 1996 when we became global, but the pace and the rate of exchange across national boundaries exceeds anything I ever could have imagined. And the virtual world, although we're sort of trapped in it, turns out to be a really good vehicle for that kind of exchange if we exploit it properly. Differences among countries, well, timing, obviously, this hit China and Italy before it hit the US in force, and we've learned a ton from our colleagues in China and Italy. Some of the networks I'm on are literally intensive care doctors from Italy or China, for example, talking to intensive care doctors in the US, virtually coaching them on respirator management and the use of steroids and all sorts of things, that the lessons learned speeding around the planet faster than I've seen those lessons ever before. Countries differ a lot in resources. The enormous success in Singapore and Hong Kong comes in part from their training that they had during the SARS epidemic, which told them how to prepare in ways that other countries have not really been able to, and they've exploited that very well. And so we have an image in those particularly highly successful countries and others about what it would be like to respond as fast as possible, adequately as possible. Countries differ in their cultures. We have a challenge of solidarity in the U.S. We're making some progress, but it's the countries that have pulled together and really been able to act as a unitary nation that seem to be most successful. My eyes are particularly tuned to the low and middle income countries, and hopefully we'll discuss them more in a future seminar. They are severely at risk. If you looked at the map that Derek showed from Johns Hopkins at the beginning of his remarks, you see these dark areas in Africa and Latin America where the virus has not yet hit. It will probably, and those countries are going to be very, very challenged with resource limitations that we haven't had to face. And we're going to have to reach across to them, figure out how to help across the boundaries of inequity at a planetary level. So it's an amazing global learning community. IHI is committed, and Derek's done a great job with the team to try to figure out how to speed this knowledge around. And we're going to do that today. So thanks a lot, Madge.
All right, Pedro Delgado, there you are in Belfast today. What about Europe is noteworthy in this pandemic? As we try to get a view of a whole continent, a whole set of countries here. Thank you, Pedro.
Thanks, Matt, and Don and Derek and James and Dom and Mike. It's so great to have you with us. Matt, there's a lot to learn from what we're seeing in Europe. There's a couple of sort of late recent developments which speak to maybe Derek's suggestion that the curve is moving at a similar speed in the different geographies. So Italy and Spain slowing down, I think it's a highlight. A lot of suffering. We spoke to a Spanish system this morning, and sort of they're getting by and they're getting through, and they're seeing the volumes reduce, but the scars are there. Italy seeing something similar, and obviously the sort of start of a slow but sort of tentative kind of opening by the likes of Denmark and Austria to start to reignite some of their normal activities. So they'll be keeping an eye on their data, they'll be keeping an eye on their numbers. Here in the UK, the number we're still on the way up to the peak, and we've been in regular conversations with mental health trusts, with acute trusts, just to understand what's happening. And three things stand out from that perspective at the, let's call it the hospital level. One is a real focus on staff well-being. How can we keep staff well physically, PPE equipment and so on, and psychologically, sort of knowing that we don't have all the answers for the management of this virus. Secondly, the sort of person-centeredness and solidarity that we've seen from the clapping on Thursday nights for NHS staff through to volunteers everywhere. It's really heartening and hopefully something that will remain with us into the future. And the third thing, which I think builds a nice bridge to our guests today, is this very, very rapid learning and innovation spirit. In the midst of a crisis, there's no alternative but to sort of surpass the usual bureaucracy. There's no black and white answers, so we should and must learn together and rapidly, both managerially and clinically, about what's happening. And we are seeing that everywhere. It's very exciting to see that. And I would say aligned to that, many organizations obviously are thinking about the recovery phase. So what happens when the volumes come down? And how can we sort of restart our activities that we have somehow put on hold for a while to focus on this very sort of high level of emergency. Match, just to finish through the Health Improvement Alliance Europe, through the conversations with our partners, and through opening channels like a similar learning hour that we're about to start on the 20th of April. We want to continue to listen with empathy, to learn, and to try and sort of share a knowledge across the sort of people in Europe that are fighting the virus. So in parallel to that, I want to invite people to check out during the stuff period, things like some of the free open school courses that we have put out there. And we're about to also launch a story sharing site, which should be a place for maybe some therapeutic sort of relief of people who are keen to write and share stories of what's happening now. So much, a lot happening, a lot of shared learning, a lot of real sort of rapid innovation and improvement happening daily, hourly, and minute by minute. And hopefully our guest today will illustrate that for us in very real terms. So I'll leave it there.
All right. Thank you very much, Pedro. All right. We're going to turn now to James Mountford and a wonderful team with him. I want to start off, James. It's not really, I know, a quick subject, but maybe just to set the scene even further for us before we get into what Nightingale is all about. How would you characterize or fill in for us a little bit more about what COVID-19 looks like in the UK and the NHS response? What seems to be working and what's difficult? Thanks, James.
So good morning or good afternoon, everyone, and a very happy Easter or Passover or whatever is your bent from an extremely sunny but very, very unusual London. So my name is James Mountford, and my day job until about 2 weeks and 2 days ago was at the Royal Free London, which is a large teaching hospital with multiple sites to the north of the river here in London. But I talk to you now from NHS Nightingale, London. Florence Nightingale is perhaps the mother of measurement in healthcare. And I don't know whether people were thinking about that when they named our suite of field hospitals about which we're going to talk today after Florence Nightingale. But it certainly seems a very apt name. And she was not only the mother of measurement, but she was the mother of rigor and of learning and of planning how to use the information that was learned to benefit her patients. And that certainly seems extremely apt. So I am here as part of a quartet. And the quartet includes Richard Bomer, who's with the Nuffield Trust at the moment, Many of you will know Richard from his writings in the New England Journal and elsewhere, with Dominic Allwood, who is a partner in crime from Imperial to what we're trying to do at the Royal Free. And many will know Dominic from her work with the Leadership Alliance, for example, and also Professor Mike Roberts, who leads UCL Partners. Mike is an old friend and has never been professionally more important to me or my colleagues here at the Excel. And he will describe what I think is a unique function that UCL Partners is providing for us. So what are we doing? I imagine, to your question, I don't think the response to COVID in the UK is any different really to what colleagues around the world are seeing. Perhaps there's a different phase of the disease, but we are in an Easter that no one has ever seen here in London. The streets are very quiet, the transport is even quieter, and the police are stopping people going to the beach to their second homes. We are in a race against time to be ready with enough hospital capacity. So that's the idea behind Nightingale. So as I imagine for colleagues, your hospitals are all surged in one way or another. You've stopped everything that you can stop. You've repurposed staff, you've brought back staff, but even that is not enough. And that's why we are sitting here in the Excel Conference Centre, which many of you will know from coming to the International Forum, which happens, the plenaries for the International Forum, to anyone who's been, happen in what is now our staff canteen. And we are trying to employ 30,000 staff to fight this disease in the main exhibition halls, which are of the large concourse to the north and south, which we're fitting out as intensive care wards. The challenge with this disease is quite extraordinary. Firstly, the setting. So you can see in the pictures there, we've had the army come and install tanks. They've turned a conference centre in about 17 days into an open hospital, and we took our first patients on Tuesday. So the setting is highly unusual, and experienced intensivists coming off their shift will describe that disorientation of their situational awareness as being a major issue in their ability to provide care. The staffing is equally an unusual thing. So we don't normally have people who have never worked in healthcare caring for patients, but that is the situation that we have. So on Tuesday, when I stood in the receiving bay as we were awaiting our first patient, I checked in with the team to receive them, and there were 6 of them. And 3 of them were experienced emergency room nurses, and 1 was a dental hygienist, and the other 2, one had worked in a shop until 2 weeks ago, and the last was a contractor to a railway engineering firm. But if that's not enough, then the disease itself is highly, highly uncertain. And we know, and Mike will speak more to this, but the amount that we know, the experts that from around the country about this disease, its natural history, who it attacks most severely, the best treatment regimes. I don't just mean drugs, I mean all sorts of things to do with complex ventilatory regimes, proning, turning, fluid balance. Doctors who've got 30-year histories in ICUs say they see physiological mechanisms moving in different directions that they've always seen move together before. And so picture turning a conference centre into a hospital in the context of a disease where you are learning every day about its biology and its treatment. So if it were not challenge enough to build a hospital in 2.5 weeks in a conference centre for, say, stroke or heart failure, diseases that we basically know how to treat, we are adding in the extra uncertainty of the biology of this very, very odd disease. We're also facing staff going off sick because it's really hard to do this work at a social distance. So everyone has deputies and those deputies have deputies, and people come to the front and they do their turn, and then they go sick, and then they come back. Personally, I wonder whether I had an extremely mild version of the disease a couple of weeks ago. Didn't think about it at the time, but that might fit a pattern. And we can talk about testing. I'm sure that's an issue in every country. It's certainly an issue here in the UK. But I think what we want to describe, and I'll hand over to Richard in a moment, is something that we hope is important for our patients here, but moreover is also going to be a concept which we can embed into the rest of healthcare in the NHS. And one of the themes that I think might run through our discussion is the way in which a national health system is perhaps able to respond where more fragmented systems like Italy or Spain have struggled. And that's about mobilizing people. We've had, 4 different bits of the British military help us to build here. We've commandeered an airport. There is no longer such a thing as London City Airport. It's called NHS Nightingale. The RAF conducting tests this afternoon here. So it's a world that none of us wanted to find ourselves in. But to quote Richard Schilling, who's one of our clinical leads here, we are here for London. We didn't want to be here, and we hope we're useful. So Richard is now going to describe the learning system, which is at the heart of Nightingale.
Okay. Hi, Richard, and thank you very much, James.
Thank you very much. So given the uncertainty that James has just described and the multi-dimensional uncertainty, we're trying to build a system that learns as quickly as it possibly can. And an effective learning system largely has got to be good at 2 things. It's got to get data out of experience and turn that into learning, but then it's got to make sure it acts on what it has learned. So we're thinking very much in terms of sort of an up and out of the patient care floor, and then a back into the patient care floor as the 2 big design sort of aspects, or the 2 big aspects of the design we're trying to put in place. So this slide here shows in sort of simple form the learning system that we're building, and it has several characteristics that I'd like to highlight for you, and then both Dominic and Mike are going to describe a couple of those in much more detail. So the simple idea is that we have to take insights and opportunities for learning that arise on the patient care floor in the contaminated zone, and make sure we can capture those and elevate them to a level in the organization where we can aggregate them, where we can make sense of them, where we can consider their meaning and understand to what extent should this learning cause us to change what we are currently doing. And as James pointed out, we are really trying to learn on 2 or 3 dimensions simultaneously. One of these is on the clinical dimension. We need to learn about the disease, its progress, the way it behaves, and the way it responds to our interventions. We need to learn a lot about the operations of building and running a 4,000 bed. If you could just go back to the previous slide, please. The 4,000 bed intensive care unit, not something anybody's done before. And we have to learn a lot about how to mobilize that workforce and keep them safe, both physically and most importantly, psychologically, because it's an intensely stressful environment that we're asking people to work in. So those ideas and their suggestions for improvement that come from the shop floor, the observations of what's working and not working well, we have 9 separate data streams in the internal data and experience data flow. They come to what's in the middle there is our quality and learning group. Now they have another input, and that's external advisory group that's headed by Mike, and he's going to describe that. But we felt very strongly that given the amount of conversations bouncing backwards and forwards on social media and the pace at which the literature is being contributed to by colleagues all over the world, we needed one entity that was going to make sense of all of that and serve as a sort of single source of truth. So the internal data, the external data from UCL partners, into a quality and learning team, and from that, suggestions for change. And those suggestions for change go to an internal change authority. That's a group internal to the Nightingale, made up of clinicians and operations people, both sides of the management house, to evaluate those changes that are substantial changes to the way we organise care, changes to the medical care itself, before that they are put into action. There's a whole group of changes, of course, that don't really need a deep dive and further evaluation, and we're making lots of quick fixes along the side as well. Occasionally, further simulation and further research is required for very important changes, and particularly changes which have a patient outcome or a patient safety implication. And we won't put a change back into action until this internal change authority has attested that it's ready to go, and it's a change that we should make for patients currently here and all future patients who are brought into the unit. Now, the key issue in that, and please, if we can go to the next slide, thanks. Yep, sorry. So the key issue here is that we're making changes on 3 dimensions or 4 dimensions at the same time. I've split out the workforce and staff wellbeing as 2. Those changes are put into action in a number of ways. We change protocols and standard operating procedures. We have daily briefings for each shift going into the contaminated zone and debriefing of the shift coming out of the contaminated zone. We also have induction for new staff, which is managed by our education and training group. And we've created a new role, which Dominic's going to describe in a moment in more detail, a role we're calling the Bedside Learning Coordinator. They have 2 jobs. They have the job of helping capture insights from the bedside, and they have the job of ensuring that everybody working in this environment is up to speed with all the changes that are being made. So they have an input and an output role themselves. So some of the changes are going to be expecting to be very rapid. Some are going to require validation and simulation, and some of them are going to require formal quantitative research. So we've tried to meld those 3 things all coming into the same place. So core to this is the role of the Bedside Learning Coordinator. I'm going to turn it over to Dominic to describe that.
Richard, thank you very much. And James, too. And as we go along and hear from Dominic and Mike, any examples you can provide? Richard just mentioned sort of 3 different types of possible changes, from the rapid to perhaps getting a little more review and then that much more review. Just an example of each as we move along would be great, just to give people some grounding on what kinds of things you might be trying to learn about so that you can steadily improve. Thanks, Dominic.
Thank you. So before I go into the detail of what's on here, I think it's important to just come back to the reason why we wanted to create a new role. For some people, they might be looking at our system thinking, we've already got a lot going on. The development of a new role could be quite complex. So why do we need it? Now, if you think about staff who are working in the current pandemic on the front line, even in their own environments and organizations, this is very stressful. They have a lot of psychological, physiological burden on them to get through these shifts and to help look after their colleagues and patients well. Going into this setting of the Nightingale, where they've never worked before, is a completely different experience and another level. And what we wanted to do was make sure that people to work was really as minimized as it could be. And one of the things that we felt would be to have an additional role that helps be the eyes and the ears of what is going on the front line, to help share the learning out, take some of the burden away of the things that need to be done, and help bring that back into operation. It's particularly, I think, important for these types of field hospitals where people don't tend to be employed by that organisation. So we're borrowing staff from around our system to come and work there. They do a long shift, but they don't have other time and ties to that organisation through management or leadership time or quality improvement time. They haven't got lots of time to be doing the work around the edges. And for many of them, they may come in a few times and do a shift and not come back. So in order to think about what would make this better for your patients and your colleagues tomorrow, that's quite a different mindset to, I'm just going to come in and do the work and go back to my original organisation. So it's a complex setting. And what we wanted to do was create a role that really helped a lot of this, thinking about what's the learning and the support for staff. Now, one of the other things is for thinking about how do you improve quality of care in these settings, and think about what does quality mean. And really, we're sort of working through all of that. So what is the new normal for safety, effectiveness and experience for staff and patients? And we're hoping this role will really do that. So let me tell you briefly a bit about the detail. So part of it is the input section you can see on the slide. It's about gathering the data and ideas from the bedside. It's about the suggestions of what is working and what isn't working in specific domains like clinical, operational, looking at the workflow, looking at whether guidance and best practice is really working for our patients and our staff. It's about then taking that data out of the bedside and feeding it up into the right forums. Now, the reason why this role is so crucial is because we're in areas where people have to be wearing personal protective equipment. We can't just have staff wandering in like they would to a normal ward, checking in on how things are and taking intelligence out. This bedside learning coordinator really is the eyes and ears of what's going on, and a right-hand person to our matrons and our senior clinical staff. They do things across a few different domains of quality. So one of the basic things is about safety, registering the incidents on our DATEX system, which is our incident capture system. That takes the burden off the staff members themselves doing that. They're also looking at the welfare of the staff on the shift and understanding how people are coping. They're also thinking about what are some of the outcomes and effective practices that are going on that really need to be changed. So they're looking across all the domains of quality. Their insights get fed up into our system along with all the other things that you would expect to see in a hospital that's fully functioning, like national audit data, incidents and complaints, all the other things. And then those go, as Richard said, to the change authority, which really looks at a few different types of problem, and Madge, you just alluded to it. So the first thing is really, if it's operational excellence that we're trying to do or a job that needs fixing, that really just needs to be done. So that might be that a particular machine isn't working, equipment is missing, etc. We would say that really that bedside learning coordinator is helping to get the snagging list, but really we're looking for the sort of higher order learning that comes out so they can help channel that into the operational work. The bits that we're really interested in are the continuous improvement parts and then the real innovation, step change, transformation. And I'll just give an example of that real sort of innovation in care piece. We heard from one of our physiotherapists who was doing a different technique, managing one of our ventilated patients, manipulating the chest in a different way, and they managed to increase the oxygen levels of that patient from 94% to 100% without changing any oxygen settings. Now, that's an example of them being a really skilled practitioner doing something in the moment, and how do we get that learning out of the bedside up to the rest of the organisation and back down again to say everybody should be doing that. Because we have a fantastic opportunity with this huge number of beds and patients in those beds to be doing best practice and spreading that really well. But what we don't want to do is inadvertently create variation and think about care where actually we're driving that gap bigger than it should be. So we want the best practice to be spread really quickly. So that bedside learning coordinator takes that change, that new way of working into the bedside every day, shares top tips, and really is an experience on the floor that can go back and help train new people coming in to say, this is what it's like to work here. So really, we are seeing this as a great role, not only at Nightingale and at other Nightingales where we're spreading learning, but actually thinking about how can other healthcare facilities think about this role as a sort of learner that brings continuous improvement and innovation into the workplace, but takes some of the burden off of the workforce who really have a very, very difficult job to do. So that's really all I want to say about the role, but we're really excited. We've had 7 or 8 shifts already. People are knocking our doors down internally to try and do this role because they think it's so important. We haven't really had to sell it hard. And we're really passionate that it will help drive best care at Nightingale along with many other things. I think I'm handing over to Mike now to talk about the opposite end of the scale, which is all of the bigger picture and external data and evidence.
Dominic, the chat has lit up with a lot of questions about the bedside learning coordinator. So, how it be possible, where did the skills come from, etc. So we'll hear from Mike, and then we can come back to some of those.
Sure, questions. I'll take some questions at the end. We can cover all those details.
Perfect, thank you. Mike.
Great, thank you. May I have the next slide? Thank you so much. So just to emphasize what Dominique has just said there, is that learning is happening in real time. There's discovery going on every minute. Whilst we're talking now, people around the world are understanding different ways and better ways of managing patients in the critical care setting. And one of the real challenges is how do we get that information out to people when there are literally thousands of people dying every day from this condition. And the traditional ways of publishing in peer-reviewed journals are just really not fit for purpose at this time. So the kind of three key points in learning I think I would make right at the beginning, and I'll try and illustrate these with some practical examples in a moment, is firstly, everything changes really, really quickly, and we have to capture that change in real time or as close to as we possibly can. I think that's really important. The second thing is that in a crisis like this, there's a lot of chaos, and there are lots of people and groups running around doing things, and there's a need for someone to take charge and to start to pull those groups together so they work more effectively and efficiently. And the third point, I think, is that that is best done by an existing organization or system rather than trying to create a new system on the run, because it takes so long to do that, you're going to miss so much. So that's where UCL Partners came in. And as you can see from this slide, we are a partnership organization of 23 NHS provider organization trusts, 9 academic institutions, covering a population of 6.2 million, although a lot of the work we do is national. And our role and remit for the 10 years that we've been in existence is to bring together the NHS with academic institutions to try to implement discovery science and innovation into clinical and social care practice as quickly as we can and at scale. And I think our funding comes from different sources, but includes our partner organizations who pay into us, but also we get some funding through the NHS. But what that gives us, though, is independence. We're not completely dependent on the NHS, and we are not an NHS organization. And that allows us a bit more agility. We don't have to go up to ask for permission before we do things. Our partner organizations include University College London, Queen Mary University of London, that actually has a faculty in Wuhan, interestingly, so that's been really useful for us, and the London School of Hygiene and Tropical Medicine, that has a massive public health resource that we've been able to pull down on. Our NHS providers include the Royal Free, where James works, University College London Hospital, Great Ormond Street Children's Hospital, Moorfields Eye Hospital, and most importantly and relevant now, Barts Health, which is the parent organisation for the Nightingale Hospital that you've just heard described, which is where we came in. Next slide, please. So initially, we were asked to try and support and work with James, Dominique, and others on the ground to pull in place a learning health system in the Nightingale. And as part of that, as you have heard, it's important that we also pull in learning not just from within the Nightingale, but learning from outside to inform practice in as close to real time as we possibly can. So we have set up a group working with evidence synthesis and system evaluators from University College London with a group of intensivists, clinicians and academics to pull together as much as we can the literature that's coming from the peer-reviewed journals, the grey literature, but also to pull together the real-time learning we're getting from clinicians on the front line, and to pull that together into something which can then be fed back into the system, which isn't an overwhelming document. And I have seen some wonderful new guidelines being produced, which are 50, 60-page documents, and that's fabulous. That's the old way of doing things, but I have to say at the current time, it's not fit for purpose. And there is no clinician working at the Nightingale who's going to sit down and read a 55-page document and pull out the relevant evidence for them. Somebody has to do that for them, and that's the kind of thing that we're doing. And sending reports 3 times a week through to the Nightingale with the latest evidence, but also the latest in clinical practice, which may change, and there has to be a health warning on that. It's not a guideline, it's not evidence-based, but it's what people understand today is the acute learning. From that, we've made a lot of connections. So in England, we have a national clinical director for intensive care medicine who links in with their equivalent in Wales, Scotland, and Northern Ireland. And the UK Health Service is now fragmented into the 4 devolved nations, so perhaps not dissimilar from the federation that you have in the United States. And so making those connections is really important, because a lot of what I'm going to talk to you about is what's going on in England. But let's not forget there are 3 other nations that make up the UK. So communication is really important too. So out of this work, we were getting a lot of requests from our partner trust to say, can you help us, please? We don't understand what to do in this circumstance. We're finding things in our clinical practice that don't really chime with the evidence that's being published in the peer review literature from China and Italy. And so we have then set up a system working firstly with the Intensive Care Society to hold knowledge sharing sessions. And they started as a UK-wide system where we brought together experts from the 10 most experienced intensive care units in the UK and got those specialists to share their knowledge in an open workshop, and encouraged communication and questions from intensivists from another 100 units in the UK to try to come together with some common challenges, but also some common understanding and knowledge of some of those challenges. We then used our evidence synthesis team to pull that together in a document, and within 24 hours of that workshop, we're able to spread that document by email, PDF, but also then got into Twitter and various other areas. So it went around the world within 24 hours. And that's the difference between what we're doing and what happens through a guidelines group and what happens through the traditional peer review literature. And to give you an example of why that was so important, and this is a little bit technical, but it's important. So the evidence from Italy and from China was that most people ending up with ventilatory failure have an adult respiratory distress syndrome picture, which requires certain ventilator settings and certain management protocols. What our colleagues were telling us was that in an earlier phase, they were seeing lots of people with respiratory failure with a ventilation perfusion mismatch and with evidence of pulmonary emboli. Now, that hadn't been described in the guidelines and the literature, but it was the evidence in the UK. We quickly put that out, and we got huge feedback from centres saying, we're seeing exactly the same, but we didn't know whether we were misinterpreting the clinical signs. The ventilator settings are totally different. The manage organs and stop them from failing is totally different. And that immediate understanding of that new knowledge and sending that out really has made a difference, I think, in saving lives within a 24-hour period in the UK situation. From that, we now have a webinar on Monday with the Intensive Care Society of Italy, of France, of Germany, and 6 sites in the US, where we're going to try to pull together a consensus of clinical practice across Europe and the United States. We then have a meeting with the health ministers of Europe, in which we have been asked to provide a similar PDF summary document for them to disseminate across European nations. And of course, we'll provide that for the US too, through our links. And that we will do by Tuesday evening. So that's the rapid way that we're trying to work together. In the UK...
Mike, may I ask you a question?
Sure.
I want to make sure that we get to some questions from the audience. And I am also inviting anyone who can stick around for another 5-10 minutes at the top of the hour so we can get to those questions, to please do so. I know some will have to go, but if you could kind of wrap up your remarks or find a good place of pause. It's all fascinating. I can, believe me, everybody is just inhaling what you're talking about, but I just want to make sure that we can get some questions to the team before you all have to leave.
Apologies. You can tell I'm very passionate about this.
I certainly can, and for good reason.
Final thing, regionally and nationally, we've helped now set up a system of collaboratives across our intensive care regions to help support the same kind of knowledge exchange with our patient safety teams and our improvement teams working together to try to help implement the change that we're finding from those clinical conversations. So I'll stop there, and I'm very happy to take questions later too. Sorry to have gone.
Oh, no, 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 please. It's we're trying to stuff as much as we can in, and we're so grateful to all of you. And just a reminder to the team, as well as our audience today, all the slides will be available to you. Get them through a link in an email from Sarah early next week, and you will see them posted to IHI.org as well. And there's a letter already. Okay, so that's in the chat. All right, let's try to get to a few questions. As I mentioned to Dominic, and in case you have also now seen the chat, a lot of people kind of lit up around the idea of this bedside learning coordinator. Can you just tell us a little bit about qualifications, where these people maybe might be drawn from in terms of existing positions they might hold in the healthcare system? Thanks.
Sure, really good question. Stop me if I'm going into too much detail, but we have defined the sort of skill set and type of person that we're interested in doing this role. What we realized when we were doing it was that in many attributes that person started off having looked a bit like a practice nurse educator who could go and support staff, think about training needs, look at safety, think about what was going on around changing management of patients. And it helped us in the first instance to help people recognize they were already playing that kind of role in another setting that they might be great candidates to do this role. We've been trialing it for the last few days, but we've had a range of people already come through it. And what we've noticed is that people from different backgrounds bring a very different perspective. So junior doctors, we're going to have non-clinical people come in, and whatever discipline they come from, they bring a very different perspective to that lens of what are the changes, what's the improvement, what's the learning. So I think whilst in the first instance, these practice nurse educators will be really powerful for getting the role up and running, we will bring and draw in other people. We are looking at how we staff this as a model. So the way the Nightingale is organised, we have a bay, which is 6 patients. Each ward, which is a long row of patients, the Nightingale ward, has 7 bays. So we have 42 patients on this very long corridor. And then 3 wards make up a zone. So our aspiration is that we think 1 bedside learning coordinator will rotate around the zone of 126 patients. They will closely sort of be at the elbow of the matron and other people. They will do sort of walking ward rounds and observational pieces, a bit like an ethnographer looking at what's going on. But where they can make change or improvement in the moment, they will do that, and they will support staff to be able to do that. So whilst we haven't put explicitly that they need improvement qualifications or skills, many of the people gravitating to these roles have an interest in research, change, learning, improvement. And so I think we'll be looking for some really blended skill sets. So we're staffing at the moment from 7 in the morning till about 11 at night. We're hoping to have an overnight shift, so this will be a 24/7 service. They scan their pro formas in at the end of their shift. That goes out and gets typed up within an hour, and we get that data back straight away.
Okay, thank you, Dominique. Here's a question that is being asked in a couple of different ways, which is any concerns, this might be for Mike or Richard or James, any concerns about making a lot of quick, rapid sorts of changes without enough evidence and experience. So that's where maybe even an example might be helpful in terms of the level of scrutiny things might get in order to that we're not introducing any harm or safety or neglect in any way. Who would like to take that one?
Why don't Richard and James do that?
Okay. Richard?
It's a great question. And it's one that exercises us all the time. First, do no harm. I mean, we are aware that the dimensions of uncertainty are legion, as I tried to say at the start. And so I think there's a sense here, which is how do we do as best we can, but recognize that nothing is going to be remotely near perfect for anybody. And I would, pick up on that example, perhaps about the physio that Dominique mentioned. So that's not something that we knew. There's all sorts of debate about proning of these patients and how you do them, how you do that. And that's never going to be in the published literature fast enough. So I think there's something about, creating this network, a learning system inside Nightingale London, a learning system which then goes out to the other Nightingale hospitals and the Louisa Jordan in Glasgow, with whom Dominique and I were on a call earlier this week. Richard was on a call with Mass General and the Brigham and with Intermountain. So I think all of these observations and types of knowing, if we call it that, are valid or potentially invalid. And you put together a puzzle and a picture and you do the best you can. And your defense mechanism is to always be asking the question, what do we know, what do we not know? And to be relentless about defining the really important things that you don't know and try to reduce that uncertainty from whatever source.
Okay, thank you, James. Richard, is there anything you want to add to that? If James covered it.
Reinforce a couple of things and make the observation that this is not an accident that we've called it a learning system. There is, as you're all well aware, a very large literature on learning organizations. But given the nature of the disease and the pace at which things are evolving, both within the Nightingale, nationally and internationally, we really have tried to craft what is in essence a system of systems. What Mike has described as system, we have a system around the Nightingale in central London, and we have another system inside the Nightingale itself. And so that's not an accident. I think the second thing I'd want to emphasize is something that Mike has pointed out. It's proven easier to kind of repurpose existing organizations than it would ever have been to create existing organizations. And we've got lucky that we've been able to do that. I think the third thing I would say to follow up on James's comments is that the nature of the uncertainty is that it is difficult to reduce on multiple dimensions. And so we have to grab data and insight and experience from wherever we can find it. But the purpose of having this aggregation within the institution, what we've called the change authority, and the aggregation outside the institution through UCL partners, is to subject everything to maximum security scrutiny that we possibly can, to make sure that we are clear we're not doing any harm. And where there is legitimate uncertainty, we're going to have to try and perform research of quality that we would find acceptable in the healthcare environment as fast as we possibly can to answer some key questions. So the whole system is built around constant scrutiny of everything that we do. We're very aware of the danger of simply aggregating anecdote and calling that a recommendation. So we're trying to wrap both quantitative as well as qualitative evaluation tools together in order to help us do that.
Thank you very much. As we are close to the top of the hour, I'm again mentioning to folks that we will go a little bit over. If anyone does need to leave, whenever you need to leave, we thank you in advance for your time today. That includes panelists and audience. And please note all the information in the chat about how to take advantage of today's program after the fact, including all the resources and the slides. And oh yes, of course, we do have a survey because we are trying to bring you things that are useful right now, and you can tell us if we've succeeded and how to make it even better. One question that has actually, I'm going to hold those questions just for a second. I think what I'm going to do, if Derek and Don are okay, they've been along with everybody. Why don't we what stands out for Derek and Don? Any thoughts or anything you think would be helpful to learn more about? Derek?
Yeah, thanks, Madge. So given that our theme was global learning, I was personally very intrigued by what Mike was saying about how they are making connections out with national boundaries. And there was some commentary in the chat about how they're doing that. How are we engaging with Italy and China, etc. So, Madge, if it's okay with you, I'd like to invite Mike just to say a little bit more about how they're doing that and what they hope to get out of it.
Sounds good.
Thank you. So it began through an organic growth, in a sense. We started to think about the learning that we might gain from outside. One of the things that seems to be the case and hasn't been commented on yet is that the disease trajectory and the survival in intensive care units in Germany seems to be very different from everywhere else in the world. So we thought it really important to get in touch, for example, with Germany, with Italy, because they have so much more experience, and with the States because, well, you guys are pretty good usually at intensive care, so we thought we should bring you guys into the picture as well. It's not trying to flatter over much with that. So we approached individuals first and asked them to point us to the relevant leaders in the fields. And through that, we were pointed to the intensive care societies in those areas, and that's how we made those contacts. Then through our academic institutions, we found that we had a lot of contacts. I mentioned the faculty in Wuhan that helped to bring in some insights from there. And then through one of our colleagues who's working in Europe at the moment with the health ministries on managing COVID, he made that connection for us to the health ministers forum, which allows us another platform to try to get involved in things. So partly it's about planning. So we sat down and thought about where do we need to go and who do we need to contact. And partly it's slightly fortuitous. But again, having an organization like our own, which has got lots of academic and clinical links around the world, helped us to start to pull in those kind of resources together.
Thank you. Don, anything you'd like?
Thanks. Just one quick reflection. I know we're getting to the end. My comment is about tempo. It's astonishing how fast this has developed, but also how fast the learning process seemed to go. So maybe James or Richard or one of you would be willing to comment on what pace you're after. How fast are you trying to learn at the fastest, and how do you maintain the rapid tempo that you seem to be using to harvest and spread lessons?
So I'll take that first, Don. So 20 days ago, I think the first kernel of the idea of a Nightingale hospital formed in somebody's eye in the center of our system. And then 19 days ago, some modeling appeared that suggested that it really was necessary and that London would need a surge capacity beyond what could reasonably be put into a hospital of 5,000 beds. So everything at Nightingale is on steroids fast. We have a system which basically beats to a daily rhythm around the clinical operational forum that Richard described. It's 4 o'clock every day, and things are taken there, they're decided, or they're taken away and then brought back the next day. But some things have to go quicker than that. So, as you will have in your hospitals, there are some safety alerts, for example, that would happen immediately and be flagged straight out of the floor. So we have many types of ventilator in this facility, such as the nature of establishing the battery of ventilators that we need. And some of those ventilators, the staff are more familiar with than others. So that would be an example of something where we might need to get an alert out of the floor to be considered and back in again. So I think we'd like to say that the rhythm is at least daily.
I think it's also fair to say, Don, that we expect learning to have different cycles and different paces. We're coming across, as you can imagine, many operational glitches which needs to be fixed very quickly. Some deeper operational problems that we hadn't expected, which would need to be addressed. We're expecting a lot of very rapid cycle learning on those things. We're coming across changes in the way we undertake our clinical work, perhaps with a slightly a shorter pace than the operational glitches. And we're imagining that more fundamental changes to the way we think about managing this disease will maybe be on a slightly longer cycle than that. So we're sort of planning for three different tack times, if you will, for the learning. And the latter, of course, the slowed because of the need to subject the more fundamental changes in clinical practice to further scrutiny before we agree to update a protocol or update a standard operating procedure. So we're really managing learning on three different paces. And I'm sure, like you, we're very worried about burning everybody out here. There's a lot of people have not had enough sleep in Nightingale at the moment, as you can imagine. And so that's why we're hoping to that we can settle down as many of these very short cycle learning episodes on the operational issues to allow us a little more time to then focus on some of the longer cycle learning, particularly around the conduct of clinical practice.
So, what about Don, go ahead. Anything?
No, I was just just expressing my thanks. These people are so busy managing.
I agree. What about emotional support for staff? And I love the slide that's here, and of course, of this, all over the world. As you ramp up with the Nightingale, are you going to be looking at some very particular issues related to resilience, support, needs of staff, given kind of very intense things they're dealing with patients and illness and possible death?
So we think that is an absolutely top-level issue. I mentioned that we've got some staff who are unfamiliar with working in healthcare setting. We've got all staff who are unfamiliar with working in the particular setting that we're asking them to do here. We are onboarding a workforce which is 3 times the size of the total workforce of the Royal Free. So the combination of those factors, I think, is to people who are really expert in this field, combined with the nature of the disease and the PPE for the environment, and the fact that you're putting yourself at risk on the floor, at least to some degree, the people who have studied this and worked in, for example, combat zones, post-combat stress, that is the frame that we're using to think about this. So there are several things we're doing around that. There was a question about whether we have psychiatrists on the staff. The answer is that we do, but we also have large numbers of what I would call peer support workers, buddies, more kind of entry-level psychological support that's available to staff. And we're really encouraging staff to use that. Many staff are staying away from home in hotels, which happen to exist happily right next to the conference centre. So again, that's a very unusual environment, which provides both opportunities and stresses. The shifts are long. Again, I think Dom mentioned that there's data from China around some of the potential complications around a 12-hour shift. So again, that's under review. There's a reason why we have a 12-hour roster. Is that the right thing? We'll learn as we go along. So, staff welfare starts with nice rainbows and signs and bottles of water and fruit as you walk along the concourse, which are not typical for an NHS hospital. But it goes right up and to this level of immediate after shift and then more ongoing access to support. And we anticipate that some staff will need that for an ongoing period of time.
We're going to go to Derek in just a moment for maybe a couple takeaways, James and a wonderful team. Maybe this final question. Somebody's asking, is there a stream of learning that has to do with management and management decisions and the role in this very rapid fire clinical learning environment? One for you, Richard.
I'm sure you can imagine how I'm going to answer that question. We are,
Yeah.
we are aware that we are running at NHS Hospital in a very fundamentally different way from the way an NHS hospital is conventionally run. And to be honest, we're quite excited about that. This does represent an opportunity to try doing things differently and make sure they're working and be rigorous about that. But if we get it right, we would very much hope that other NHS institutions look at what we've done, both in specific terms and also philosophically, to think through, are there ways we should be managing hospitals, all hospitals going forward. There are a couple of things of obvious note. In the environment here, the access to senior leadership and rapid senior decision making is quite remarkable. Those processes are often much more difficult and much slower in an established institution. And, you know, I think James and I would both like to think that we are suggesting mechanisms by which people working at the front line of clinical care who've got good ideas would find it in the future much easier to get those ideas elevated up the organisation and acted on more rapidly than they often are in the context of the full-size NHS. So I think that this is a common point of conversation. Are we really coping with COVID, or are we learning lessons in coping with COVID, in addressing the threats and challenges posed by COVID that will carry over into the very long term and change the way in which we do things? And I and Dom and Mike and James, I think we all believe that we are, and we're very mindful, therefore, about trying to make sure that building for the future informs our rigor in the present.
Richard, James, Dominic, Mike, we have learned so much from you this hour, and we know you're kind of running on fumes. Do hope people get sleep and rest. We know it's a bank holiday in England and Good Friday, and I don't know if that means any rest for the weary, but we are immensely in gratitude and grateful for all that you've contributed. Just in case you need to slip out the door here, move on to other things, we're going to wrap up a couple takeaways from Derek here, and then just a few little notes from me. And I want to also thank this amazing audience for your participation. Derek?
Thanks, Madge, and let me add my thanks to the whole team from London who have so generously shared what they're learning, and of real incredible value. There are three things, Madge, that I took away. Firstly, as we are flexing our systems to meet these these challenges, it's essential that we design and redesign our learning system for quality. Second, as we do so, we better make sure that it connects the people at the bedside to system leadership, and that those two-way connections are kept open in real time. And third, I think an important point about the life cycle of discovery and learning, which is now in minutes and hours, and not in months and years, as it once was. And I think that applies both to our clinical knowledge and to our improvement knowledge. So those are three things I'll take away with me, and I hope others have also gained some knowledge over the course of the last hour or so. Thanks very much.
Okay, thank you so much, Derek. Thank you, Don. Thank you, Pedro. I know we couldn't see and hear everyone in necessarily equal increments, but I hope you got a lot out of the discussion and the learning today. And if we didn't get to your specific question, please stay connected with us at IHI as we work on making more of what we're learning available. We'll certainly stay very, very closely tuned to what's happening, with Nightingale and James and the team and we'll share that on IHI.org and make that quite visible as the material becomes available. A reminder, virtual learning hours are one of the free benefits of IHI's new membership program, and these programs, this is now our third of 8, are happening during unprecedented times, and we're thrilled to be sharing them with the entire IHI community. Again, my thanks to our panelists today. Please be on the lookout for the archived edition of today's show posted to IHI.org. Val on our team at IHI is very fast, so it may be up there later today, but some of you may actually be sleeping by then. So look for it perhaps on the weekend or Monday. We're going to be back next Friday at 10 a.m. Diving into another interesting and important topic, ethics and guidance on standards of practice in a crisis. And those details will soon be on IHI.org. We wish everyone the best. We wish you health. We wish you an opportunity to learn on the go and then a chance to reflect, maybe for a few quiet moments at a time. For the Institute for Healthcare Improvement, I'm Madge Kaplan.